Hello and welcome. I'm Gwen Taylor, Senior Developmental Editor and Webinar Program Manager at John Wiley & Sons Publishers, and I'm delighted to introduce today's webinar titled Atypical Femur Fractures, Addressing the Problem from a Patient-Centered Perspective. This webinar is being co-sponsored by Wiley Publishers, GE Healthcare, the American Society for Bone and Mineral Research, and the Journal of Bone and Mineral Research. GE Healthcare provides transformational medical technologies and services to meet the demand for increased access, enhanced quality, and more affordable healthcare around the world. The women's healthcare business at GE has been focused on osteoporosis solutions for the past 43 years and has recently received clearance from the U.S. FDA for its new Atypical Femur Fractures software. GE Healthcare helps medical professionals deliver great healthcare to their patients. The American Society for Bone and Mineral Research promotes the study of bone and mineral metabolism through annual scientific meetings and ongoing webinars, publications such as the flagship Journal of Bone and Mineral Research, and advocacy and interaction with government agencies and related societies. In 2017, ASBMR is celebrating 40 years as the leading professional, scientific, and medical society in bone, mineral, and musculoskeletal research. During today's program, we encourage you to submit your questions throughout the event by clicking on the Ask a Question box at the bottom of your screen. Your questions will not be seen by any of the other attendees. The webinar will be recorded and available for viewing in the next few days, and we will send you an email with details on how to access the on-demand webinar and how to download a PDF of the slides. So now it's my pleasure to introduce today's speakers. Elizabeth Shane is a professor of medicine and vice chair of medicine for clinical and epidemiological research at Columbia University. She currently serves on the advisory council for the National Institute of Arthritis, Musculoskeletal, and Skin Diseases. She is also past president of the ASBMR and has served on the editorial board for the Journal of Bone and Mineral Research. Sundeep Khosla holds numerous distinguished positions at the Mayo Clinic in Rochester, Minnesota. He has served as chair of the NIH Skeletal Biology Development and Disease Study Section, on the Council of the National Institute on Aging, and as president of the ASBMR. Dr. Khosla currently serves as the editor-in-chief of the journal Bone and has served on the editorial boards of numerous other highly regarded journals. Malachi McKenna is a board-certified internist and an endocrinologist at St. Michael's Hospital and St. Vincent's University Hospital in Dublin. He is clinical director of the Metabolism Laboratory and co-director of the DEXA unit at St. Vincent's University Hospital. And finally, Deborah Gold is a professor of medical sociology at Duke University Medical Center. She is also senior fellow at the Duke Center for the Study of Aging and Human Development and directs the postdoctoral research training program in aging there. So let's go ahead and get started with this impressive group of highly qualified speakers. Dr. Shane will be speaking about patients' perspectives on the problems of atypical femur fractures. Dr. Khosla will give an overview of the problems and potential solutions here. Dr. McKenna will talk about putting DEXA monitoring for AFFs into practice. And Dr. Gold will follow up with addressing patient concerns and building trust. These are their financial disclosures. And so let's go ahead and get started with Dr. Shane, who will give an overview on patients' perspectives on the problems of AFFs.
Thank you, Gwen. My task today is to describe recent experiences that Sundeep Khosla and I had with patients who have had atypical femur fractures and how those patient interactions have affected our thinking. In 2010, I had the privilege of co-chairing the first ASBMR-sponsored task force on atypical femur fractures, and in 2014 we reconvened the task force for a second time to include all the new information available since 2010. After both task reports were published, I was contacted by several patients who had had AFFs, and other colleagues have had similar experiences. However, In general, the feedback from AFF patients after publication of the task force reports was positive and supportive, and patients thanked the task force for trying to address the problem. There was, however, some pushback on the task force conclusion that AFFs are rare. There is an active AFF online patient support group that was organized by Dr. Jennifer Schneider, an MD PhD board-certified internist who had an AFF early on in 2001. The support group has now more than 200 members online, and they appear to work together to try and raise awareness about AFFs among physicians, patients, and the media, and some contact physicians who write in support of treating osteoporosis. Dr. Schneider also published a case series of 81 patients with AFFs in the JCENM in 2012. In June of 2016, Dr. Khosla and I were invited to co-author a perspective in JBMR on the looming crisis of undertreatment of osteoporosis, in which we pointed out that despite decades of progress, patients were refusing to take drugs that had demonstrated benefit in preventing fractures. Within 2 weeks, we both had received more than 35 emails from patients, mostly AFF support group members. Each patient described their own AFF experience, the trauma they had experienced, and the life-altering effect it had had on them. Reading these emails was very upsetting to both of us and had a cumulative effect of changing our thinking about how best to approach AFFs. Collectively, these patients had several similarities. Most were relatively young, active, health-oriented women. Most had started bisphosphonates in their 50s and 60s for osteopenia. Most emphasized that AFFs have lifelong sequelae. Some comments included, femur snapped with a loud crack, worst pain I've ever experienced, life forever changed, multiple surgeries, long-delayed healing, chronic pain, immobility with a cane or wheelchair dependent, loss of independence, inability to continue working, additional fractures, and financial drain. In view of AFF patients, AFFs are not rare. They point out that AFFs are frequently underreported, and they are frequently miscoded because there is no specific code as of yet. Many commented that their surgeons see many patients but do not report each one. Others commented that many surgeons and physicians are unaware of AFFs completely. Many emphasized that we need to direct education on AFFs to generalists who most often prescribe bisphosphonates, such as nurse practitioners, internists, and obstetric and gynecologic providers. Several said the risk is low unless it happens to you. It is also the stated belief of AFF patients that the profit-driven pharmaceutical industry is to blame for the problem. They believe that because the market was larger for osteopenia than for osteoporosis, that led to a push to prescribe the drugs for prevention of bone loss rather than as a treatment for osteoporosis. Many think that pharma misled doctors into believing that prescribing bisphosphonates to postmenopausal women in their 50s and 60s was the way to prevent osteoporosis in old age. Many are very angry about what they view as irresponsible marketing. One quote from an AFF patient was particularly noteworthy. It appears as if the presumed number of fractures that may happen without treatment is a statistic of more value to you and your society than the real people who lost their health on many levels, lost their dreams, spent their retirement funds on medical bills, and in most cases live in pain every day. This experience helped us to understand better the patient perspective on AFFs. We are committed to the goal of preventing osteoporotic fractures. However, collectively, these human stories had a powerful impact on our thinking. We realized we hadn't truly been listening to patients, and we also realized that quoting statistics was not going to be effective in persuading patients who really have severe osteoporosis to accept effective treatments. we realized that in order to treat patients with osteoporosis, it is essential that we also take proactive steps to protect patients from having AFFs and to regain the trust of patients with osteoporosis. This webinar represents one step, fully supported by ASBMR, toward realizing these goals. Next, we have Sundeep Khosla, who will review several approaches we and others have been considering over the past several months that we hope will improve treatment of patients with osteoporosis while also addressing the problem of AFFs from a patient-centered perspective. Sundeep?
Thank you, Elizabeth. So I'm going to cover an overview of the problem that we face as clinicians in terms of both the problem of osteoporosis as well as the challenges in management. So I don't need to remind this audience that osteoporotic fractures lead to substantial morbidity, mortality, and socioeconomic impact. Hip fractures, which are the most devastating of all fractures, are associated with a 25% one-year mortality rate and lead to 65,000 deaths each year in the U.S. alone. And over half the patients who experience hip fractures are permanently incapacitated, and up to 20% spend time in a skilled care nursing facility. It's not well appreciated that, in fact, the number of women who will experience a fracture in 1 year exceeds the combined number of women who will experience incident breast cancer, myocardial infarction, or stroke across all ethnic groups. And fractures also have considerable socioeconomic impact, leading to an estimated burden on society of approximately $18 billion US dollars and 36 billion euros. And these costs are expected to double by the year 2050. Now, the incidence of hip fractures is changing, as shown on this slide, which is data from Dr. Lewicki and colleagues. And you can see on the top part of the slide that going back to 2002, hip fracture rates were steadily declining. The dashed line starting around 2012 shows what the numbers would have been in 2014 and 15 if that trend were continuing. However, as you can see, the decline in hip fractures has actually plateaued, and there is some concern that this may actually begin to rise again. Now, in this slide, Dr. Lewicki argues that at least part of this is due to a decrease in osteoporosis diagnosis related to less DEXA testing, which is perhaps tied into the markedly reduced reimbursement for DEXA. But clearly, there are also likely many other factors that are contributing to this decline or to this changing incidence of hip fracture rates. Now, one of the things that could be contributing to this is concerns about side effects related to bisphosphonates. This slide is from Jha and colleagues and shows U.S. Google search activity for the first and most widely used bisphosphonate, Fosamax or alendronate in its generic form. And you can see there was a spike in search activity around 2006 when there was the first lawsuit filed for osteonecrosis of the jaw. A second spike labeled B when there was a link between bisphosphonates and atrial fibrillation, and then a major spike labeled D when there was a news story on Fosamax and atypical femur fractures. This slide shows that there has been also a changing pattern of bisphosphonate use. The top graph shows the data in women and the lower one in men. And you can see bisphosphonate use peaked around 2005 to 2006 and then has markedly declined down to less than 50% of the peak, particularly in women, but also in men. Of more concern is that even in a group where there's near uniform agreement that treatment is warranted, namely after a hip fracture, this slide from the work of Dr. Solomon and colleagues shows that compared to 2002, when almost 40% of patients were getting a bisphosphonate or other osteoporosis medication after a hip fracture, that this probability of getting treated after a hip fracture has declined down to around 20% in 2011, and that downward trend is continuing. So there are a number of potential explanations for the declining bisphosphonate use. Certainly, fear of adverse effects particularly given the timing of the onset of declining use shortly after media reports and FDA announcements about safety concerns. But there could be appropriate reasons, for example, more appropriate targeting of bisphosphonate therapy to high-risk individuals, and certainly appropriate cessation of use after treatment for some years and or switching to alternative therapies. So I don't think that we can necessarily distinguish based on these ecological data about which one of these is the correct explanation. But I think there's increasing and convincing evidence that fear of adverse effects is certainly contributing to this decline. This was highlighted in this article by Gina Kolata in the New York Times in June of 2016. And you see the title, the headline, that fearing drugs' rare side effects, millions take their chances with osteoporosis. And there's a quote from the article indicating that millions of Americans are, in fact, missing out on a chance to avoid debilitating fractures because they are terrified of exceedingly rare side effects from drugs that can help them. So the problem for the field of osteoporosis is that patients who now clearly need osteoporosis therapy are either not being offered, or if offered, are choosing not to take bisphosphonates or, in fact, any other osteoporosis drug due to the fear, particularly of atypical femur fractures. In addition, the incidence estimates for AFFs or atypical femur fractures with prolonged use, bisphosphonate use, vary widely, anywhere from 3.2 to 50 to 100 per 100,000 person years. Nonetheless, the best estimates are that with bisphosphonate therapy in the appropriate individuals, 80 to up to 5,000 fragility fractures would be prevented for every possible AFF that's induced by treatment. So the patient and physician attitudes are shaped by the media attention given to AFFs. I just provided you one example based on the article from Ms. Kolata. But there's also concern, particularly amongst patients, that AFFs may be vastly underreported. And I think Elizabeth alluded to this in her section of the talk. It's clear that simply quoting statistics to patients without carefully listening and addressing their concerns is not going to work. So the challenge to the field is that there is, in fact, an urgent need to demonstrate to patients that we have heard their concerns and are addressing them both in the short, intermediate, and long terms. And I believe the key is to diagnose AFFs before they occur, and over the longer term, better identify those patients at increased risk even before starting osteoporosis medications. So over the short term, I think education is going to play a key role. We need better patient education regarding prodromal symptoms of AFFs, in particular new onset and significant groin or hip pain. We also need physician education regarding taking these symptoms seriously and defining an appropriate and cost-effective evaluation plan to exclude incipient AFFs. Perhaps brief, standardized, and simple-to-administer questionnaires for common prodromal symptoms of AFF could be used that could be linked to prescription renewals by physicians. Also, over the short term, we can implement monitoring. So we need agreement from the bone density manufacturers to modify existing DEXA scanners and basically the scanner software in order to obtain what I call a femur monitoring scan that includes the region of the femur where AFFs occur. Ideally, this would be covered by insurance and could be done with or independent of standard bone density testing. This really needs to be considered as part of the cost of therapy and not to be confused with bone density monitoring for efficacy. As such, the cost of this safety monitoring test should be very low. So importantly, Hologic currently offers this option, which is FDA approved, but it's only on its newest scanner. And to date, it's not possible to retrofit older scanners from Hologic with this new software. This shows the Hologic website where they indicate the clearance by the FDA for the single energy femur scan to visualize features associated with AFFs. So as I mentioned, this needs to be made available as a low-cost update to all existing scanners. This is a monitoring scan that's analogous, for example, to monitoring liver enzymes for patients on a statin or renal function on patients started on ACE inhibitors. The other major manufacturer, Lunar, is actually in the process offering a similar option as an update to existing software, which has very recently been approved by the FDA. This can quantify focal thickening and can also retrospectively analyze patient databases. My colleague, Dr. Malachy McKenna, will talk in much more detail about DEXA monitoring for AFFs, and he will go into some of these features in greater detail. This shows an example of a femur monitoring scan from the GE software. You can see on the left is a scan which includes a much wider range of the femur than the typical scan for bone density monitoring. And the red arrow indicates where there's a focal abnormality consistent with an incipient AFF. And the software can actually quantify that abnormality in what's called the beaking profile, and as shown on the plot on the right, it can keep track of this over time in terms of monitoring the progression of a possible AFF. So the advantage to this, and again, Dr. McKenna will talk about this in much greater detail, is that the femur monitoring scan for AFFs can be instituted fairly rapidly, potentially as a simple upgrade or simple software upgrade to existing scanners. It's proactive, it makes sense clinically, and something we can do today to begin to address patient concerns. I agree, and I believe it is important to guard against false reassurance. So a negative scan doesn't imply that patients or physicians can ignore symptoms even if they occur soon after a negative monitoring scan. So over the intermediate term, I think it's important to try to identify higher risk patients even before they start bisphosphonate or other anti-resorptive therapy. And a potential approach to this was described by Majub and colleagues in 2016, and they compared femur geometrical data in 56 AFF patients versus 112 controls with traumatic or fragility fractures. And the image from the right, which is from a plain radiograph, shows some of the parameters that they examined. For example, D is the neck shaft angle, which I'll come back to. So based on their analysis, as shown on this slide, they identified a number of features that were different in patients who went on to develop atypical femur fractures compared to controls. And again, one of them was this neck shaft angle, which was more acute in the patients with AFFs. So this would suggest, for example, that patients who have a more acute neck shaft angle may be perhaps putting more stress on the lateral aspect of the femur, which in the setting of prolonged anti-resorptive therapy may make them more susceptible to an atypical femur fracture. Obviously, much more work needs to be done to expand and validate these findings, but this is the kind of information that could be available perhaps even from a baseline DEXA scan, which using the appropriate software could be quantitated and identify high-risk individuals. Over the longer term, an important area is pharmacogenomics, and proof of concept of this was provided by Roka Ayatz and colleagues at the 2000 ASBMR meeting. They identified mutations in the GGPS1 enzyme by whole exome sequencing in 3 sisters, all of who sustained atypical femur fractures during treatment with bisphosphonate. These mutations impaired the function of this enzyme, which is in fact the target enzyme that's inhibited by bisphosphonates. In this study, they also identified other susceptibility variants, but certainly larger collaborative pharmacogenomic studies are needed to potentially use a genomic approach to identify patients who might be at increased AFF risk following bisphosphonate therapy. So there are a number of additional long-term approaches. Certainly, there's a strong case to be made for continued new drug development in the field of osteoporosis. The current anti-resorptive drugs that we have are associated with a low risk of these side effects, and clearly having new drugs that don't have these side effects is important. In addition, the best evidence is that the anti-resorptive drugs that we do have established anti-fracture efficacy for around 5 years, but the efficacy of long-term anti-resorptive therapy remains to be established. So clearly the perfect anti-resorptive drug has not as yet been found, and certainly there is a need for better anabolic drugs. We also need coordination of recommendations and guidelines regarding screening and treatment of osteoporosis, and perhaps most importantly, we need enhanced patient engagement strategies, and Dr. Gold will go into those in much greater depth in her section of the webinar. So to summarize then, concerns over AFF risk could in fact undo decades of progress in finding new treatments for patients with osteoporosis. Most importantly, these concerns are preventing patients who clearly need treatment from either being prescribed medications or taking them. And it's clear that quoting statistics to patients has not and is not going to work. So as a community, we need a focused and effective effort to address patient concerns. Now, before I turn it over to Dr. Gold to talk in depth about patient engagement, I wanted to briefly summarize ongoing and planned initiatives. So Elizabeth and I submitted and published a perspective earlier in 2016 on the crisis in the treatment of osteoporosis, where we highlighted many of these concerns. Now online, we partnered with a number of other leaders in the bone field to identify a potential path forward, which goes into much greater detail some of the points that I've highlighted in the webinar today. We also had a special session at the 2016 ASBMR meeting highlighting this problem and potential approaches to address it. At the ASBMR meeting, we also had individual meetings with Hologic and Lunar regarding the availability of the femur monitoring software, and it's really great to see that that is moving forward with both companies now having FDA-approved software for performing the femur monitoring scans. ASBMR has also developed a call to action to address the crisis in the treatment of osteoporosis. I won't go through each of the bullets on this slide, which essentially highlight the problem of osteoporosis and why this call to action is critical. The main point I want to make is that to date, 37 organizations have pledged to increase efforts for the call to action, so I think this effort is gaining momentum worldwide. ASBMR is also working with the Center for Medical Technology Policy to develop a multi-stakeholder initiative. The goal of this is to identify and prioritize key barriers to appropriate rates of osteoporosis screening, diagnosis, and treatment to prevent fractures. And this will incorporate the attitudes, values, and preferences of key stakeholders, which of course include patients, but also primary care and other physicians, insurance companies, a whole host of other parties that have a stake in fracture prevention. CMTP will collaborate with ASBMR and key stakeholders to develop strategic options for addressing the barriers that are identified, and then most importantly, they will develop a plan for disseminating and implementing the strategy. Now, another effort is through the NIH Office of Disease Prevention, and this really grew out of discussions that Dr. Shane and I had with Dr. Steve Katz, who's the director of NIAMS, and Dr. Joan McGowan and others at the Institute. Dr. Katz, once he learned about the impending crisis that we face in the treatment of osteoporosis, decided to engage a number of other NIH institutes as well as the Office of Research on Women's Health to apply to the NIH Office of Disease Prevention, who have agreed to take this problem on. So ODP will provide an objective external review of the current state of the science related to fracture prevention and identify important gaps in knowledge. As noted in the second bullet, this is an effort that involves multiple NIH institutes and the Women's Health Research Office. ODP will also work with AHRQ to solicit proposals from evidence-based practice centers to prepare an evidence report addressing the key questions being posed. And this will take about 18 months to 2 years, at the end of which there will be a major conference which is similar to previous NIH consensus conferences, and the findings and recommendations of the conference will then be published and also made freely available. So I'm going to turn this over now to Dr. McKenna, whose group was one of the pioneers in putting DEXA into place for monitoring AFFs as they evolve, and he will go into that in much greater detail. Malachy?
Sundeep, thank you for the introduction. I'm going to start with the first of 3 vignettes showing DEXA for the early detection of incomplete AFF. This is the case of a 73-year-old woman who'd been on alendronate for 10 years. She presented with a complete AFF that needed to be fixed with an intramedullary nail as an urgent procedure. However, afterwards, it transpired that she was complaining of pain in the mid-shaft of her femur. She had incomplete fracture on the other side. This didn't heal, so she had elective insertion of a medullary nail on the right side. There is an enormous morbidity gap for the patient and a technical gap for the surgeon between inserting a nail electively and as an urgent procedure. This is an opportunity for DEXA to try and identify at-risk cases early. In fact, this lady had a DEXA scan performed in our unit a few weeks beforehand, both to the eye and by the edge detection system of our DEXA machine. An incomplete AFF was actually identified. There are 3 different approaches to detecting an incomplete AFF using a DEXA system. The first can be extending the femur field length at the time of the DEXA scan. The second can be adapting a feature for imaging the spine. And the third can have it as a customized feature for your DEXA machine. As regards the first approach, Fergus McKiernan, a rheumatologist at the Mayo Clinic in Wisconsin, was the first to describe DEXA machines for diagnosing incomplete AFF and also for showing serial change. This can actually be performed on any model of a DEXA machine, both lunar and hologic systems. He had a simple yet ingenious idea of extending the femur field length by an extra 7 centimeters. This allowed for visual inspection of the outer surface of the femur. That's the lateral surface where incomplete AFFs start. And Fergus McKiernan also showed that this has actually no effect on the BMD measurement on the GE lunar. Larry Jankowski in Chicago similarly showed there was no effect using hologic system. So here is the second vignette showing the DEXA system identifying an incomplete AFF. This is a patient who had participated in a monitoring study we performed who'd been on bisphosphonate therapy for 10 years. The extended femur field DEXA identified a local reaction on the lateral surface of the femur. Plain X-ray diagnosed that she actually had an incomplete AFF. A nail was inserted with minimal morbidity and with an excellent outcome. There is another approach, and that's high-definition imaging of the entire femur. This is performed by adapting the image for the spine. So if a DEXA machine is capable of high-definition imaging of the lateral spine, then it can be adapted to conduct high-definition imaging of the femur. Using technical advice from Larry Jankowski in Chicago, we adapted our hologic DEXA machine to get an image of the entire femur. There are at least 3 advantages to this approach. First, the quality of the image is far superior, as you can see, compared to the extended field DEXA image. Secondly, the full extent of the femur is visualized. And finally, this is a very fast technique, taking about 20 seconds for each femur. It can have no effect on the bone mineral density measurement because actually it's a separate examination. So the next is the third vignette of a lady who had been on bisphosphonate therapy for about 9 years. At the time of presentation, she had intractable pain on her right thigh, such as great difficulty walking. The extended image clearly shows an incomplete AFF. The high-definition imaging is possible to see this beacon appearance not only on the periosteal cortex, but also on the endosteal cortex. The fracture was confirmed on the X-ray image, and she had elective insertion of an intramedullary nail with a minimal morbidity and with an excellent outcome. To date, what I have shown you are approaches by DEXA operators in the field who have adapted their DEXA systems. As Sundeep showed you earlier, the DEXA manufacturers have responded. GE Lunar have introduced an AFF software upgrade. This can be used on any of their machines Prodigy and the Lunar iDEXA that are under 10 years old. It's a form of DEXA imaging that starts over the patella with a distal and proximal femur component. As Sundeep showed you very nicely, by measuring the cortical width, it can profile the width in order to detect areas of focal thickness. And in addition to that, it can actually identify serial trends because it can analyze previous scans. Hologic approached it from a different way, and they have added a feature called the SE Femur to the new DEXA system, the Horizon series. This likewise is FDA approved. In addition to getting very high definition images, a number of other features are available, such as annotating the image, magnifying it, and making additional measurements. It should be noted that the effective radiation dose is very low. Finally, I'm just going to mention about 2 monitoring studies that I've performed in our practice in Dublin. Both of these are similar in design in that consecutive patients presenting for a DEXA study in our unit who've been on bisphosphonate therapy for more than 5 years were enrolled in the study. The first study used the first technology of extended femur DEXA imaging. The prevalence of AFF was very high at 2.7%. This is actually similar to reports using different imaging modalities such as MRI and CAT scan that were in the literature at that time. The second study, performed a few years later using the higher definition imaging, actually showed an AFF prevalence of 0%. Finally, it's my practice in our unit to monitor patients for incomplete AFF at the point of service. At this stage, it's my great pleasure to introduce Dr. Deborah Gold, who will be addressing patient concerns and building trust. Thank you.
Thank you so much. Osteoporosis patients, or those people who fear they may have osteoporosis, have 2 concerns right now that go far beyond how much calcium they should take or how much exercise they should do. People with other illnesses have these similar concerns, and yet somehow they seem to impact osteoporosis patients more and have led to refusal of treatment and subsequent consequences of that. These 2 concerns, fear and distrust, are prevalent and problematic for people with osteoporosis. What are the fears about? Well, number 1, concern about, is osteoporosis really a disease and treatable, or is it a consequence of aging that we can't do anything about? And if it's the latter, why should we take medications for it? Secondly, fears that this disease has been created by physicians who can then order expensive tests and pharmaceutical agents that might improve the physician's financial situation. Thirdly, the fears that these medications do not effectively treat osteoporosis, and we've heard about that to this point. And then finally, the concern that we're really addressing here, that these medications cause side effects that are worse than osteoporosis itself. And that can often come from not really thinking through what osteoporosis can do. There is no question but that the media have generated this fear and promoted the concerns that these patients have. And here we see two websites that are saying exactly what I just mentioned, that osteoporosis is not a disease. It's the body trying to correct some sort of imbalance. And again, on another website, a story that came off of National Public Radio accusing Merck of inventing osteopenia in order to sell Fosamax, which was to them a blockbuster drug. Now, patients are also becoming afraid of their doctors and their other healthcare professionals. They feel that medications are being pushed on them, medications that don't work, and that doctors are not taking their best interests and their outcome to heart. And that's very concerning, because if you don't trust your doctor, who are you going to trust? Now, the two areas of outcomes from these medications, osteonecrosis of the jaw and the atypical femoral fractures, are found throughout the internet. And all of these sites are saying that the drugs cause these problems in large numbers. One website told its readers not to take the drugs for osteoporosis, and then the ironic fact, of course, that they believe these drugs cause weak bones, and Fosamax in particular causing thigh bones that crumble to bits. A bit of an exaggeration, but something that is commented on frequently on the internet. Another issue that comes up is that these websites claim that orthopods have many, many patients who come through with these atypical femoral fractures, their thigh bones snapping like a twig, which they comment is rare because the femur is one of the stronger bones in the body. Now, what should patients be afraid of? They should be afraid of osteoporosis and the fragility fractures that come along with it, because those fragility fractures lead to a series of problems that include deformity, pain, disability, morbidity, and mortality. It's unfortunate that the fear is much more about the drugs than about the disease. In addition to fear, patients are feeling attitudes of distrust. Their fear grows, they're questioning their physicians, they don't know where to go, they look on the internet, and they don't know what the right answers are, so they don't trust anybody. Especially problematic is the fact that they're not trusting the healthcare professionals who work with them, and that means that they will not attend to the kinds of treatments that might really help them. As was mentioned earlier, the number one target of this distrust are big pharma. And Merck and Procter & Gamble here, who are responsible for two of the oral bisphosphonates that have been associated with these atypical femoral fractures, are criticized throughout the internet about developing diseases, falsely advertising, and creating these thigh fractures that are problematic and concerning. In addition, patients are feeling distrust toward their physicians. I found this book on Amazon.com, Lies My Doctors Told Me About Osteoporosis, and the article said, my doctor tried to put me on a drug, then I read that they make bones brittle, no drug for me. So again, making decisions not based on fact, but on fear. If we look a little bit further about distrust, we see the obvious distrust of the medications themselves. Why am I taking a drug to prevent fractures if, in fact, it increases fracture risk, as this one site says? And then thousands of broken bones caused by Fosamax in patients who are doing nothing more than operating on a day-to-day basis. Again, exaggeration, but very prevalent on the web. We have a whole lot to do, as you heard all of the previous speakers say, and there are no easy answers to the challenges that we have. If there were, we would have found them already. But the most important thing is to develop trust between patients and their healthcare providers. We need to help patients feel that providers are competent, and trustworthy, and that competence is not simply a result of their medical education, but is cultural competence as well, understanding the issues raised by race, by religion, by age, by socioeconomic status. Communication is key. There is no doubt about that. And the fact that we have to be consistent about the information we give out, and we need to concur with other organizations. Once trust is reestablished, then we can develop the patient-physician working alliance. There are many studies on this topic, and there is no question that when that working alliance exists, patients do better. Remember that patients are making decisions based on the psychology of this issue as well as on the biomedical aspects of it. But as you see in the third bullet, this working alliance is associated with patient adherence, satisfaction, and improved patient outcomes. If we trust both ways and we work together, then patients can get better. How do we build trust? Well, I think one of the things we need to do is to help educate patients to what the consequences of untreated osteoporosis are. Right now, many people believe that the side effects of the medicine are worse than the disease. And we haven't done a very good job of educating them about how serious this disease is. How do we help them evaluate the credibility of what they see on the internet, especially about some of the osteoporosis factors that seem to be exaggerations? And then what is the absolute risk of an atypical femoral fracture if I go on an oral bisphosphonate, for example? How do I see that in comparison to what might happen if I don't take it? There is certainly evidence that patients feel that atypical fractures are more common than perhaps the literature has shown. And finally, this doesn't happen overnight. I've been an educator for 30 years, and I know that it takes a long time and a commitment on the part of the educators and the patients to changing the understanding and behavior. We need to attack this at multiple points: individual providers, their practices, at hospitals, as well as professional groups like the ASBMR or advocacy groups like the NOF. And that part of this educational process is helping patients believe in the medical system again, to understand that the point of all this that we've heard is to treat osteoporosis to help improve patients' quality of life and to reduce their risk of atypical femoral fractures and the fragility fractures that go along with osteoporosis. Thank you very much, and we'll go to ask questions right now.
All right. Thank you very much, Dr. Gold. So as she said, let's go ahead to the question and answer segment. So if you haven't yet submitted a question for our speakers, now is the perfect time to do so by clicking on the Ask a Question box at the bottom of your screen. The way we're going to do this is I'm going to present a question, and Dr. Khosla will direct that question then to the appropriate presenter. So first question here is, how many AFFs might be avoided if physicians did not use anti-resorptive agents to treat patients whose osteoporosis is caused by low bone turnover?
So maybe I can take that on. We don't know the answer to that. We have not been traditionally tailoring bisphosphonate or other anti-resorptive drug treatment based on bone turnover. Theoretically, perhaps patients with lower existing bone turnover could be at increased risk, but there really is no good evidence to support that. I believe that may be a question that has to go into a research question that includes the whole issue of better identifying patients at risk for atypical femur fractures based on the femur geometrical characteristics that I mentioned, or pharmacogenomics. It's a great question, but I don't think we have the evidence to answer that question.
Okay, on to the next then. What are the rates of AFF from the use of Prolia versus Fosamax?
Again, the largest post-marketing data that's available is with bisphosphonates, and most of that related to Fosamax or alendronate. I think the problem has been is that because in the large clinical trials a non-zero rate of atypical femur fractures have been found with other anti-resorptive drugs, such as Prolia and even the sclerostin antibody romosozumab. Even though the Romo is an anabolic, it also has anti-resorptive effects. So because these have been found with other drugs in large clinical studies, when patients ask physicians whether the other drugs cause them, the answer is yes, although we don't know the rates relative to bisphosphonates. So I think it's unclear whether some of these other drugs have a lower rate of atypical femur fractures or a higher rate. We just don't know. But because of the fact that they've been observed with the other drugs in primary care physicians and in patients' mind, it's a side effect related to all osteoporosis drugs.
Okay, on to the next question then. What is the evidence supporting the fact that the resolution of the new DEXA software is sufficient to detect incipient AFFs? Is this published?
So I'll turn this over to Dr. McKenna. Malachy, do you want to take that on?
Yes, Sundeep, thank you. Obviously there'll be some DEXA operators in the field who've been using this for a while and adapting their machines, but published evidence. I expect that I know that there are a number of investigators who are using the DEXA systems, both the GE Lunar and Horizon Discovery, and I would expect we're going to see reports of that and presentations at the International Bone Meeting.
So Malachy, I'm not sure if you're finished, but you were very quiet on the line. Can you speak a little louder?
Yeah. At present, there's no published information using the new DEXA systems that have been offered by the companies, GE Lunar, which is the AFF software update, and then the Hologic Discovery, Hologic Horizon series. I know there are a number of investigators using them, and I expect to see presentations at the international bone meetings in the coming year. Hear that?
Okay. Yes. Although it's still a bit quiet, so you can, for the future questions, be sure to give us a yell. We'll go on to the next question now. How do I get information on the online AFF support group, and what is the best way to link my patients who have already experienced AFF with this online community?
Elizabeth, do you want to tackle that one?
Sure. Actually, I don't have detailed information about how to access the online support group, but I think it should be fairly easy to get by Googling the support group or Googling Dr. Jennifer Schneider. She comes up at the top of your search, and I think that would probably be the best way to do it. I do sometimes communicate with Dr. Schneider, and so I can probably get that information about how best to do it if you wanted to contact me later.
Okay, next question. Is there sexual dimorphism in atypical fractures, or are there fewer of these in men because they aren't treated as long with the medications?
That's an important question. Maybe I'll also have Elizabeth address it because Elizabeth chaired 2 task forces related to this. To my knowledge, the vast majority of these have been reported in women, but I believe that's just because, that's where the bisphosphonates have been more widely used. I don't know if there's a difference in the propensity to get these based on sex. Elizabeth, any thoughts on that?
No, I agree with you, Sundeep. I think that especially in the virtually, I think probably more than 95% of, or even higher of cases have been reported in women. It probably is higher than that, and I think that that's largely because these are appear to be a side effect of long-term use, and that has been most prevalent in women who are more likely to be treated with osteoporosis drugs anyway because they're more likely to fracture and have low bone density and be at risk for fracture. So I don't think we know the answer as to whether there's a true sexual dimorphism or whether it's a factor just related to who is actually receiving the drug.
Okay, on to the next one. Is the incidence of AFFs similar in the U.S. and outside the U.S.?
Again, Elizabeth?
I would say that it's probably similar. There is a suggestion, both from data coming from within the United States and looking at various subgroups of patients, particularly Asian women that may be at greater risk. It's interesting that one of the sites that reported these fractures earliest was Singapore. The other was, of course, the United States. So it may be that there is a greater propensity for women of various Asian ethnicities to sustain these fractures, and we don't really know if that's true, B, if it's because they tend to be smaller and take the same amounts of the drug, or whether they tend to be more compliant and take things long term. We really don't know the answer to that, but I would say there's a possibility that that might be true.
Okay, on to the next question. We have an incredible number of questions that, of course, we can't quite get entirely to all of them, but we'll get to as many as we can, and we may go a few minutes over if everybody's all right with that. Next question. What is the best way to start working with patients to establish trust in a patient-provider relationship?
So I'll have Debbie address that one.
I think the worst way to do it is by bringing up statistics and clinical trials, et cetera, as reasons for your recommendations of particular drugs. Treating them like an equal, saying to them, okay, there are 9 FDA-approved drugs for this disease. This is what we use them for, and these 3 are the ones I think might work best with you, or this one might work best with you. What do you think? Now, physicians don't have a lot of extra time. We all know that. But this is where having somebody in the office or in a practice in a hospital who is designated as the osteoporosis information specialist, could be a nurse or another person like that, a social worker, could do that to begin the establishment of trust. They are going to bring to you quotes from the internet saying, for example, that this book says doctors lie about this. And the fact is, if you can show them that there is consistent information from different websites through different publications, et cetera, that will go a long way in getting them to trust you.
Okay, on to the next question then. Should we be routinely extending femur field length for patients that have been on bisphosphonates for extended periods of time, for example, greater than 5 years?
So I think that's going to come down to clinical judgment because, some of this is based on what makes sense clinically rather than hard evidence. I can tell you what I would do, which is that if I'm going to keep a patient on a bisphosphonate for longer than 5 years, certainly around year 4 or so, in my own practice, I would, now that we are getting the new software, I would start looking at the region of the femur using DEXA where these AFFs occur, as a way to at least begin to try to screen for the presence of any abnormalities that might be consistent with an AFF. And I think Dr. McKenna presented reasonable evidence from his experience that this in fact can identify these abnormalities before the fracture actually occurs. Now, obviously, more work needs to be done, and there should be additional data coming out as this is implemented. But to me, that makes sense from a clinical perspective. I think the other question is, what do you do after 5 years? Do you go on a drug holiday? Do you go on to a drug that might stimulate bone turnover and bone formation like teriparatide? I think those are other clinical decisions that need to be made as a patient gets to about 5 years on a bisphosphonate or other anti-resorptive drug.
Okay, we have time for 2 or 3 more questions, I think. Next is, using DEXA imaging, if localized reaction is seen on the lateral surface of the femur, what should be the next step?
I don't know if Malachi's connection is still working, but maybe, Malachi, can you take this on? You might have to speak into your phone, given that you're over in Ireland.
Okay. Can you hear me there? Once the abnormality is seen, that's the localized reaction, there are 2 possibilities. There either was a prior incomplete fracture that has healed, or maybe there is a present fracture, but just you won't see it with the DEXA system. So if a patient has an abnormality, I think they need an additional imaging approach. It could be just a simple plain X-ray, or it could be more sophisticated imaging with a CAT scan or MRI, or even an old-fashioned radionuclide bone scan. If you find evidence of a fracture, then you have to make a clinical decision about whether you're going to intervene surgically or whether you're going to monitor them for a while.
Okay.
Yep. Yep.
Yes, heard that just fine, thanks. Yep. Okay, next question. It says, the media and patients have done a wonderful job sensationalizing these side effects. What has the ASBMR done to sensationalize the benefits of osteoporosis treatment, for example, preventing the next fracture or preventing the hump or preventing nursing home placement after a fracture?
So that's an excellent question, and I tried to summarize efforts that ASBMR and other stakeholders are making. I think this call to action is, in fact, a major effort to disseminate information about the benefits of treatment and put the risks in appropriate context. I believe the partnership with CMTP, which is a group that really works on health policy and how these types of issues can be addressed, will be quite fruitful. And I think particularly important is this effort through the NIH Office of Disease Prevention, because part of the problem is that in one way or another, not necessarily financial, but we who are within the field are viewed by patients or even primary care physicians as intrinsically conflicted, because we're advocating for a disease that we may care deeply about, and that these are the treatments that we work for. So I think this Office of Disease Prevention effort by NIH is going to be done by people who are outside our field and will be perhaps the most objective and transparent assessment of the benefits versus the potential risks of treatment, and also identify key gaps in knowledge where further information needs to be obtained. So I think this has to be a multi-pronged effort that includes all the stakeholders, and then, as Debbie pointed out, also concerted efforts to specifically address patient concerns and deal with them as partners in shared decision-making rather than just quoting clinical trial results to them.
Okay. Next question. Can you comment on the role of genetics in AFF and what future studies are likely to be done to address this possible link?
Yeah, I mean, I think this is a particularly exciting area. Pharmacogenomics is starting to be implemented into practice in other areas of medicine. For example, at our institution, it's being done to look for rare side effects related to allopurinol treatment. And I think more and more of that will permeate our clinical practice. The abstract that I referred to was a unique situation where there was a mutation specifically in the enzyme that's inhibited by bisphosphonates. But I know Dr. Doug Keel and others are putting together ideas for larger scale studies that involve many sites to really begin to identify potential risk variants beyond the specific ones that were identified in the abstract from Spain. But this is a long-term effort. It's going to take many centers working collaboratively, perhaps even if we can get partnership with the AFF support group, because there's a pool of patients who've had these who may be willing to contribute their DNA to help with this effort. So I think that's a fruitful area to pursue, but it may be several years down the road. Over the shorter term, some of these other measures like monitoring with the DEXA scan or using the DEXA to actually identify perhaps geometric features and a combination of geometric features that could be incorporated into a risk score that might be predictive of a higher risk of developing AFFs. That may be more achievable as we move, to continue to work on the pharmacogenomics aspects.
Okay, we'll go on to the last question here just because of time. You talked about the patient and physician concerns about atypical femur fractures, but what about concerns regarding osteonecrosis of the jaw?
So again, Elizabeth has chaired all of these task forces, so I'll turn it over to her to address that.
I think that in the issue of osteonecrosis of the jaw is also a concern for patients and also for physicians. I think it's actually interesting that osteonecrosis of the jaw was reported in patients first who were on high-dose bisphosphonate treatment for various types of cancer. Many of them had been on bisphosphonates at very high doses for a few years, whereas the atypical femur fractures seem to surface in a community of patients, those with osteoporosis, that had been on low-dose treatments that we use for osteoporosis for longer periods of time. And it may be that dose and duration have a lot to do with whether one might develop osteonecrosis of the jaw or an atypical femur fracture. I think in my clinical experience, and I believe that the data support this, the risk, such as well as we can quantify the risk of either issue in patients with osteoporosis, the risk appears to be considerably lower in patients for osteonecrosis of the jaw than atypical femur fractures at the doses that we used commonly to treat osteoporosis. So while I think it is definitely a concern in the minds of patients and physicians, I don't think that the evidence is as strong linking it to bisphosphonate treatment in the doses that we use to treat osteoporosis. That's osteonecrosis of the jaw, I think, is going to turn out to be less common than atypical femur fractures, as best we can tell. That is based on epidemiologic data from Europe, from Germany, from a lot of studies that I've seen. And my clinical experience and that of our group, I feel that it is less of an issue. However, that doesn't mean it's less of an issue in the minds of patients.
All right. Well, we are beyond out of time, so I'm going to conclude the question and answer session now. But I would like to tell you that today's webinar has been recorded, and it will be available for viewing in the next few days. We will send you an email with details on how to access the recorded webinar along with a PDF of the slides. So on behalf of today's speakers and our sponsors, GE Healthcare and the American Society for Bone and Mineral Research, we sincerely appreciate your attending today's webinar, and we look forward to your attendance at future events from Wiley Publishers.